All Americans deserve to be healthy and happy and prosperous. Yet decades of chronic illness, regulatory capture, and structural failures in our healthcare system have left our nation unwell. 70% of American adults are overweight, and nearly 1 in 3 adolescents has prediabetes. Treating chronic disease costs us $4 trillion a year. For too long, the medical establishment has framed conditions like type 2 diabetes, obesity, and hypertension as lifelong, chronic, and progressive. Americans were inundated with the message that medication was the only answer. Healthcare has been too expensive. We've suffered from workplace shortages, crushing administrative burdens, and uneven access to high-quality care. America also endured 4 years of administration that was openly hostile to innovation and failed to recognize the revolutionary potential of artificial intelligence. The Biden administration imposed heavy front-loaded compliance requirements such as mandatory red teaming and expansive reporting that slowed healthcare AI development at the very moment we needed speed and flexibility and accuracy. Its regulatory approach favored large incumbents with deep compliance teams, disadvantaging startups and research labs, and risking a less competitive, less dynamic health AI industry. It also scattered sweeping AI oversight responsibilities across dozens of federal agencies, creating a convoluted interface for government and enterprise. President Trump and Secretary Kennedy have charted a different course for health and innovation in America. At HHS, we are refreshing what is stale, rebuilding what is broken, and discarding what is wrong. And one of our best builders is Tom Keane. Tom and ASTP are building the policy foundation for technology that gives patients access to their information in real time, gives patients real choices in their care, and gives patients the tools they need to make the best decisions for their health. Tom's work on data liquidity, affordability, and access, and tech advancement is foundational to all of our efforts. 30 years ago, John Gilmore said, "The net interprets censorship as damage and routes around it." And I would say, Tom does something similar. Tom interprets data blocking as damage and routes around it. And TEFCA is central to making America healthy again. Interoperability, as we all know, has been a dream for decades. I worked on it a little bit 25 years ago. And TEFCA is the statutorily recognized department-wide and successful framework for nationwide health information exchange. At HHS, we're focused on strengthening and scaling a single trusted interoperable backbone that works across programs, across payers, across providers, and across tech platforms, rather than creating a parallel system to add complexity without delivering value. That clarity means for developers, for providers, and most importantly, for patients, it matters. Treating patients without a full picture of their health can lead to care gaps, medication errors, and adverse events. TEFCA is changing that. Because of Secretary Kennedy's and Dr. Keane's leadership, TEFCA's growth has exploded from 12 million exchanges to 500 million. They've been supported by a great team, including Mark Atala, Sam Cardle, and Steve Posnack, all of whom are wonderful leaders. The ability to exchange, access, and use your health information is crucial to solving many of the problems that have plagued our health system for years. Technology can address issues of affordability, quality, and access in enabling research into the root cause of chronic disease, and with AI, create clinical tools that will transform how we provide care in this country. Our mission is clear: care that is affordable, accessible, and empowering. The work of ASTP and CMS on real-time pharmacy benefits is a critical step in improving both affordability and access. By adding new transparency to prescription costs, patients and prescribers can make real-time comparisons and identify lower-cost alternatives within a patient's coverage. Research has shown that when leveraged by providers, real-time pharmacy benefit functionality helps a typical patient realize over $100 in savings on diabetes medications and nearly $1,000 in savings on specialty medications. We're also supporting efforts to help people who want to make healthy choices know what those choices are. Giving them access to good nutrition information, information about healthy food and exercise choices, and knowledge of preventive measures that can prevent chronic disease before it starts. Artificial intelligence is making medical care more affordable, accessible, and accurate. We want doctors, nurses, and pharmacists to practice at the top of their license. During the Biden administration, HHS officials gave a non-governmental organization, CHI, the implicit power to regulate health AI. They allowed CHI and their big tech backers to function as government-backed gatekeepers to the industry. We put a stop to this and restored an open, competitive process to ensure AI serves patients, not insiders. We're investing in AI that is not just imagined, but deployed. I'll give you a few examples. CMS is building better payment models for AI-enabled care. FDA is enabling AI to play a greater role in clinical decision support. Utah has taken an important step forward by allowing AI to assist with prescription refills with no human in the loop. As chairman of HHS's AI Governance Board, I'm encouraging innovation, regulatory clarity, and wide adoption everywhere. My office is coordinating AI policy across HHS using 3 policy levers. First, regulation. We're providing regulatory clarity to the industry, reducing unnecessary burdens, and focusing oversight where clinical risk is real. Our approach is risk-based and proportionate. Second, reimbursement. We're building durable mechanisms to pay for AI technologies in ways that reward value and support deflationary care delivery. Payment policy is one of the most powerful determinants of whether AI can scale. We are proceeding deliberately, using demonstrations of pilots to build a credible evidence base, and then we will pursue permanent reforms. Third, research and development. We're investing in AI that is not merely developed in labs or tested in isolation, but implemented in real-world care settings. Our focus is on implementation, scalability, and impact, not just technical performance. These efforts provide clarity to developers and clinicians, reduce unnecessary regulatory friction, and allow FDA to concentrate its limited resources on higher-risk technologies while accelerating adoption of low-risk tools. This collaboration is helping to meaningfully improve access, reduce costs, and evolve beyond traditional clinical decision support with appropriate safety, effectiveness, and accountability. And we're not stopping here. President Trump and Secretary Kennedy recognize and understand that the federal government has a critical role to play in clearing unnecessary barriers, protecting patients, and aligning incentives so our most innovative solutions can reach clinicians and patients at scale. We're removing regulatory barriers, enforcing the law to ensure appropriate data flows, providing clarity where it matters most, testing reimbursement models to build evidence, and investing in research that translates into real-world care. Our goal for AI in healthcare is faster learning, broader adoption, and better outcomes. By aligning regulation, reimbursement, and research, HHS is ensuring that AI strengthens our healthcare system over the long term while supporting clinicians and improving patient care. Last month, I announced the Advocate program. Advocate uses agentic AI to reimagine care delivery for cardiovascular disease. By focusing on care delivery, not just discovery, Advocate seeks to demonstrate how AI can fundamentally improve outcomes while lowering costs. Advocate is building a bridge between our cutting-edge research agency and ASTP to help ensure that interoperability efforts encourage frontier technologies into healthcare. We also have an initiative to use AI to strengthen support for family caregivers and sustain the networks that prevent the healthcare system from shouldering the full burden of care. My office recently partnered with ASTP on an AI request for information to get broad input on how HHS can accelerate adoption, how AI can improve patient and caregiver experiences, reduce provider burden, improve quality of care, and lower costs for consumers and government alike. Please share your comments with us by February 23rd. That's next week. Internally, we've deployed large language models to 60,000 employees to boost efficiency and productivity, and thousands use them every week. We have 3 LLMs for all those people. We're hiring more AI specialists to advance research and train colleagues to use AI effectively. As AI tools become more intuitive, employees can focus on their expertise while using AI as a partner. Our efforts to accelerate AI adoption are guided by the real needs and experiences of those developing these tools and those delivering care. AI won't replace the compassion and expertise that define our health system, but it can amplify both. Together, we can ensure that innovation serves us, not the other way around. Of course, government cannot match the ingenuity of industry. To anyone who's passionate in our mission to make America healthy again, the federal government needs top-tier technical talent to maximize transparency, accelerate regulatory approvals, and reduce friction on innovation. So we are hiring. We are hiring data scientists. We are hiring engineers. We are hiring AI native builders. We are hiring all kinds of tech people. And we can't compete on salary, but we can compete on mission. If you watched the beautiful rollout of TrumpRx last week, showing how regular Americans can save up to 75% on insulin and many other deep discounts on many other drugs, and you also noticed the extraordinarily beautiful UX of TrumpRx, that was partly designed by the CTO at HHS, and I need a lot more Zachs, so I'm hiring. So everyone in this room probably knows someone who would enjoy using technology to fight fraud, mine data for science, make healthcare affordable, and build the future. Please come work with us. Thank you very much.
Ladies and gentlemen, please welcome to the stage Tom Keane, Amy Gleason, and Ryan Howells.
Can't see anybody out there. How is everyone doing? I think there's a few people out there. It's good. We're super happy to have Amy and Tom here. I think what I'd love to do is start with some framing. So a few years ago, I kind of came to the conclusion that there's really kind of two types of people in the world. There are those who kind of view the world in a scarcity mentality. There are winners and losers, and if I don't win, then you have to lose. And they view the world in a very kind of narrow perspective. And then there are those that really view the world in an abundance mentality. What are ways in which all of us can win? What are opportunities where we can actually all come together and figure out a way where we can actually do this for the common good and figure out ways where we can actually solve these problems that we've had for kind of a long time? I think there's many in the audience. I've had like 10 questions in the last 24 hours where they've said, are ONC and CMS competing? Are they collaborating? What do they do? Do they like each other? Do they hang out sometimes, right, related to that? So TEFC has been around for 9 years, roughly. Well, 21st Century Cures, 2016, right? But the idea is that you're the new kid on the block, Amy, right? So you've been around for now 7 months, right? We really got started in September to some degree, right, related to it. But give us a sense of like why this is more an abundant mentality rather than a scarcity mentality.
First of all, Tom and I are friends, as well as all the others. We were even at dinner last night. We get along very well. We work very collaboratively together. So the last time I was in the government, I helped write the provider access rule in 2020. And when I came back this time in 2025, I realized that that doesn't go into effect until January 1, 2027. And so I wanted to try to find a way to make things move faster. As many of you know, I have a daughter that has a rare disease. She sees 12 doctors, takes 21 pills a day, and gets 2 infusions a month. She has 47 patient portals, and I live this journey of healthcare interoperability with her every single day. And so I wanted to say, okay, how can we do things much faster than 7 years? So I know that our friends at ASTP ONC are doing a lot of rulemaking, and that's the way they have to go through this regulatory framework. But I look at companies like Anthropic, who put out MCP servers, and OpenAI immediately adopted it, and other big labs. And in other parts of technology, people don't wait for regulation to change everything. And so we decided to do a voluntary effort and try to be an accelerator so that we can make the job of ASTP ONC easier. So we put out kind of a vision and said, a challenge, if you will, and said, let's go by March 31st and prove that some of these things we've been talking about that should work on paper because they're already in regulatory framework or rulemaking, they should work, so let's make them work by March 31st. And so we started off with about 60 companies in July at the White House, and we made a pledge and said, let's do this, and we created 12 different working groups. We have a Slack that's public and private working together, which is very hard to set up in case you ever wanted to know. Getting Slack in the government with public-private is very hard. But we have 12 working groups that are meeting with a public lead and a private sector lead together. And they've been working defining this minimum viable product for March 31st, and then we have a second goal for July 4th. And so we're on progress. We have over 650 companies, many of you in this room, have pledged to do this and are working together collaboratively. And so I think we're going to see great progress. We've already knocked down a lot of barriers, and it's a way to provide testing and prove what works. And it's kind of more like a giant hackathon or connectathon. If things don't work, then we don't have to wait for regulations to change, or we can just do it the next day and change it and try something different. Once we prove it works, and that makes it easier for our friends to do in regulation. But we really hope we can stop regulating so much and have more voluntary effort and do things faster.
Tom?
Yeah, and I will say, Amy and I are friends. Our paths crossed in prior administrations. The only problem with being friends with somebody in government is government rules prevent her from buying me dinner. So I'm really looking forward to when our government service is over, so I can leech a dinner at one of her fancy restaurants in Nashville from her. Now, I agree with Amy. You know, the relationship has been very collaborative, and the initiatives are set up to be collaborative. So as a practical matter, we talk all the time. We provide each other technical assistance. We harumph about how we're having struggles navigating the bureaucracy of government and the like. But there's constant communication about how to make the work that Amy is doing at CMS and the work that we're doing collaborative and complementary. So, you know, my colleague Steve Posnack published a blog post called The Speedboats and the Tide, I believe it was called. And the analogy is that both can bring you into shore. The tide will eventually bring you into shore, but speedboats can actually get you there more quickly. And so we view the work that they're doing in CMS as an accelerator. They can come up with solutions to problems that have long plagued network exchange. So for example, their work on the digital identity and patient matching implementation guide, which I was looking through on the Slack channels the other day, is something that as it matures and gets voted on by the people in the Slack channels, is something that we can consider porting into TEFCA. That's excellent work. Amy has taken on the Herculean lift of trying to clean up the provider directory situation. That's very bold, and they are actually making huge progress. And so obviously a provider directory is something that will help network exchange across the board. And we also consult with each other on regulation. The other day I was talking to my colleagues in CMS, as there's a potential that we may have to look at the certification program and what happens if somebody loses certification for their health information technology. I wanted to make sure that my colleagues at CMS would be supportive of that. And they've indicated yes. Similarly, Amy helps give us huge amounts of input to our HTI 6 rule and other rules. So there's a great deal of collaboration. Now, there are also differences. TEFCA has a public-private partnership governed by agreements, contracts, and the like. And if you want to take a look at it as people climbing up a mountain, people have to go up that mountain together in a pack. What Amy has done is taken Dr. Oz's mandate to use the convening power of government to advance the national interest, and she's run with that. She's pointed to the top of the mountain and said, everybody's got to get up there. You've got your own workflows. You're taking a pledge to get to this place by this time, and we will help you, and we will give you the resources, and we will give you the communication forum, but you can get there quickly. And so there's a slightly different approach. There's also a little bit of I should say there's a certain brilliance in the way she's managing this. I think you have 4 children. Is it 4? Yes. So anybody with 4 children knows, I think, Ryan, you have 5, right?
That's right.
Yes. Talk about herding cats. Getting the kids out the door to school in the morning is a crazy thing. So Amy is doing it at scale on the CMS networks. There's 600 pledgees, and getting them to all go to the same point in a reasonable amount of time is a great challenge, but they're really moving with it. I think there's also a little bit of a difference in focus. The primary focus of TEFCA is network-to-network exchange. I think that the focus of the CMS health tech ecosystem, and you can correct me if I'm wrong, Amy, is broader. So for example, there's a lot of focus on patient-facing apps and patient-empowering technology. So while there are slight differences, they're completely complementary.
I should have added that, actually. Yes, so we are doing the tracks for patient apps, and we've had requests to have many more pledges. So if you have ideas for pledges, we are listening. But the other thing that we're doing is operational use cases and trying to get payers and providers to work together. And so we're testing a lot of that out so that we can progress that. Things around quality measures, claims data for providers, and payers to be able to query to get clinical data after a claim has been submitted. And so those are kind of some things that are really a little farther out in acceleration and trying to get those moving.
I've kind of described it to people as like, Amy's running the largest early adopter FHIR B2B and B2C program in the country. And Tom is memorializing scaling and standardizing it across different networks. I mean, that's kind of how I've been describing it. And so this concept that like they're competing is just completely false, as you guys have said. And this concept, more importantly, is that it's important to join both, right? Because all the QHINs and all the providers and schooling all the payers are now in yours and eventually will be in Tom's. So there's this concept of like, how do we make sure that we get early adopters? There is nothing more important in the work that we've done at Levitt Partners that we have seen as early adopters. We have to have early adopters to test this stuff out, to make that happen.
And I will say that, I hear all the time people say, oh, we didn't get input into that, or, I don't have a way to get my feedback in. And both through TEFCA and the CMS aligned networks in the ecosystem, this is your chance to give that feedback. And if you are not participating, other people are, and they have loud voices, and they will get to have their preferences and you won't. So make sure you're participating in both of them.
Awesome. Tom, you mentioned yesterday that you released HTI-5 in December, eliminated roughly about 50% of the cert requirements. I think a lot of us has been observing this and been in the industry for a while, kind of looked at it really as half the story in terms of what is going on. But then you just teased us so much, Tom, in HTI-5. Like there's this quote in HTI-5. I have to read this quote because it's one of my favorite quotes that you had. I don't know who on the staff wrote it, but it's probably Elise or Steve or somebody, but I was super interested. We intend to sharpen the certification program's future focus to prioritize FHIR APIs, based APIs, that one, enhance automation and API performance. Ooh, that's awesome. 2, move beyond read-only interactions. Ooh, that's super awesome. And 3, expand the scope of data available to support clinical efficiency, patient-centered care, and timely reporting, public health, quality government programs, and use cases. Tom, how should we be thinking about this? Like, was HTI-5 half the story? What's this tantalizing Easter egg stuff in HTI-5? This is like Easter egg stuff.
Yeah.
This is super exciting.
You've stolen my thunder. You read out what we put in the rule. And, so, yes. On HTI-5, I will say we've left untouched 19 of 60 certification criteria. So you could probably think of it as nearly 2/3 of the certification criteria are either being removed or modified. And we're pivoting from regulating the base functionality of the EHR, which really has a great deal of market inertia behind it, and in which there are essentially market standards, and we're pivoting towards regulating interoperability. And what does that mean? Well, it means regulating application programming interfaces. It means making sure that they adopt the most advanced standards for data exchange, including possible successor standards. It means that robotic process automation and agentic AI should be able to exchange information. It means that the APIs actually have to perform. It doesn't do you any good if there's huge latency. It means that the ability to onboard and use the API has to be accessible. It can't cost too much, and it can't, and the onboarding process can't be too burdensome. And this is what we're looking at. I have to be careful, my lawyer's sitting in the front row. We're looking at these things and would be curious to hear from all of you what we should put in our next rule, which we're targeting for putting out in the summer, assuming that all of my staff don't quit because we've already put out 2 RFIs and 2 roles. So yes, that is half the story. The nature of the beast in government is to get things done quickly. You sometimes have to parse it out. So in HTI 5, we removed regulations. That sort of thing gets through OMB very quickly. We can focus on a single action. HTI 6 will look at the next phase of regulation, which will be regulating interoperability. You know, the other day I was reading the Slack channels that Amy set up, and one of the commenters said they would really like to see provider-level FHIR subscriptions. And he said, I really hope to see that in HTI 6. So we hear that, we take that, and we think about it in our rulemaking. So yes, it's half the story. We're really, and I'd be curious to hear from you guys. What do you guys think about this pivot? We going in the right direction?
I think yes.
We love it. Absolutely. Let's do it. For individual access services, we run the Karen Alliance. We have all of these 50 different apps that are actually accessing data, and they will tell you the API response time sucks. It's horrible. And it largely has to do with the fact that, number one, let me just rephrase that. It is wonderful in the sense that they can get connected to the endpoints, and they can get connected to any provider or payer endpoint in the country. It's bad in the sense that we still have challenges because based on the networks that we have and the infrastructure we have, we're waiting sometimes 20 minutes for responses. So I would just say, to your point about performance requirements, I think the time is now for us to do it. It sounds awesome. And I think it sounds like, Tom, you really want, as far as the comment period in HTI 5, to be able to say, what would you, reading HTI 5 in detail, what do you want to see, right? It sounds like, is that fair?
Yes.
Okay.
I've had the opportunity to meet with stakeholders yesterday, and we were telling them, they were telling us stuff that might be a little out of scope for HTI 5. We said, go ahead and put that in the HTI 5 comments. And I should say that the request for information that we jointly put out with CMS in the spring has informed a lot of our thinking. The responses to that were outstanding, and that joint effort has really yielded some great outcomes.
So, Amy, as Tom mentioned, you're taking on the audacious goal of redoing the provider directory. We've talked about the fact that I didn't realize, I thought CMS only had 2 provider directories. You had said they have 6. We didn't even.
It's 8.
Oh, it's 8 provider directories. There's 6 that are hidden under some cover somewhere at CMS. There's been so many companies and the federal government that have failed in the past in this effort. Why do you believe that CMS is going to be successful this time?
So I don't think CMS has actually ever tried to really solve this problem. They've had different provider directories for different purposes. Like NPES is where you register for your NPI number, and PACOS is where you enroll in Medicare. And Care Compare was meant to take that data and put it to consumers. And then there's MIPS provider directories, et cetera. But I don't think anybody's ever said, hey, let's actually put all this together and figure out how to have one source of truth. Yes, lots have done it in the private sector, but I think the difference is that people have to go to CMS and do this, at least in most cases twice. So at least everyone has to do it once. And so we also believe that we've gotten there with technology and that people are frustrated enough with this in the industry that there's momentum to do this. The estimates are $6 billion a year wasted in just trying to keep provider directories every single year, and they're still not very accurate. So basically what we decided to do is to take all the data that CMS has through these different 8 directories and combine all of that information together and figure out what we think is the most accurate for all the fields we have, and then work with the private sector and get a bunch of the private sector data to see where we match up. If we get a bunch of private sector data sources and they all have the same data for one of the fields, then we probably don't need to spend a lot of effort working on that. But if they all have something different for the address or for their endpoint or something else, then that's probably where we should focus. So that's what we've been doing. We started our efforts on interoperability. So our March 31st release will be all focused on interoperability and will be provider hierarchies, so where providers practice, what groups they go to, what hospitals they go to, et cetera, and how to connect to them. So what networks do they participate in, both QHINs and CMS-aligned networks? What are their FHIR endpoints? How do you connect to them? We'll also have apps that are in the ecosystem, registering in that, maybe not by March 31st, but probably soon thereafter. And we'll be adding payers in as well. And then we'll eventually add in the plans that providers have and continue to grow over the year to where eventually you register for MPI there and register for Medicare there. So it'll be an iterative process. The very first, very baby version will be March 31st and focus on interoperability.
So this group is going to be able to see that March 31st and provide input. Is that fair?
Yes, and we're asking everyone in the private sector, as you see changes, to use an API to update it there. So if you go hit an endpoint and it doesn't work, or you think they're in a data sharing network and they're not, or their license is wrong in a state, or whatever it is, address, phone number, then we want you to tell us, hey, this is the right one, or maybe just, I don't know what the right one is, but this is wrong. And that will help us to go and clean up the data and work on it.
Awesome. That's fabulous progress. Tom, recently there's been some calls for additional kind of transparency in TEFCA, and you showed kind of aggregated statistics in terms of the growth of individual organizations within TEFCA itself. Can you speak on a little bit about how do we get more transparency into really who has actually moved over, when they're moving over, how do we plan that? There's a lot of organizations that talk to me about things like, I just don't know, do I need to be in care quality and in TEFCA? When do I move to TEFCA? Should I be in both? How do we get some more transparency into exactly who's moved, when they've moved, what your plans are in terms of how this operates? What are your thoughts?
Yeah, sure. During my tenure, I've really tried to expand the transparency into TEFCA operations. And we understand that the first word in TEFCA is trust. And we understand that part of trust is transparency in operations, processes, and procedures. So as you guys know, we've started putting out the TEFCA work products for public comment. And you can also subscribe to, and I want to make sure I have this right, the TEFCA Topics and Change Management webpage, which gives updates on framework agreements, standard operating procedures, and other work that we're doing in TEFCA. Additionally, we've set up methods for subject matter experts to come in and comment on TEFCA. And the recognized coordinating entity also has routine calls in which they answer questions and give updates on TEFCA. We have our TEFCA participation map, and I think in generally when people move over to TEFCA, they make a pretty big announcement about it. And when a new QHIN is added, that becomes a press release. So there's a lot available online. Additionally, we're asking, just in the overall goal of more transparency, we're starting to ask the QHINs to grab us more data that we can share so that people understand how TEFCA is operating and what's going on inside of it. And I'm also happy to hear from everybody here and everybody who participates in Health Information Exchange what would be helpful, what sort of transparency is needed, both into our operations and into how people are joining the network. So would love to hear from all of you.
Yeah, go ahead, Em.
And to add to that, part of the provider directory is publishing some of this data as well. So the networks, the participants, and also the traffic. So how many individual access requests have you gotten and how many were responded to at the provider level? And I think that will also start to carry some transparency.
Yeah, part of it is that as queries go across the network, they want to know, one, are they getting responses, but also who has actually looked at this information and are not giving a response, right?
Right.
And so it's also false negatives as well. It's like, what does that actually start to look like? That helps give more understanding of where the breakpoints are.
And as a patient, you should be able to see who's getting your data. So just like you can see somebody pinging your credit report, you should be able to see who's accessing your data.
That'd be amazing. That'd be really amazing.
That's part of the Health Tech Ecosystem Pledge.
That is part of the Health Tech Ecosystem Pledge. We'd love to have an audit log of all the places in which our data is being requested for. That'd be fabulous. All right, in the last remaining time we have left, let's talk about success factors. So let's just give it a 3-year window, end of the administration. Tom, let's start with you first. What does success look like for you at the end of the 3-year tenure?
A lot of factors. The first is I would like to make sure that both ASTP and the CMS line networks succeed, so that's first. Secondly, we're laser focused on affordability, and our HTI 4 rule put out standards for e-prior authorization and real-time pharmacy benefit. Putting out standards is only a first step. Getting these to actually work, where the information that is exchanged is accurate, that it's exchanged efficiently, and that it actually makes a difference in both the patient-provider experience as part of the lift that we're undertaking over the next several years. I'd like to see expanded use cases and participants in TEFCA. I'd like to see patients be able to get their data in one place. I'd like to have a patient be able to grab their phone, download all of their information, and know that it's comprehensive so that they can organize it and so that it empowers them. I'd like to see modern capabilities implemented into EHRs like we alluded to in HTI 5. And I'd like to see overall Secretary Kennedy's MAHA agenda and vision succeed.
Amy?
So I think this is pretty personal to me. So my daughter that I talked about is having surgery next week on her ankle. And she had to go and get a CD disc and drive it across town to her doctor, twice to 2 different doctors. She had to find out through asking her favorite robots what effects her meds could have on her surgery recovery, and tell her doctor that she needed to change some things around to get the timing to work with her surgery. She was told that her surgery would cost $1,200, and it turns out it was $125, and it made her question whether to even have the surgery at the beginning of that. And so my dream is that at the end of this 3-year period that she won't have to do any of that anymore, that she will use her identity to get all of her data in one app. She'll be able to use conversational AI to get good guidance all of the time, maybe not have to go to the doctor's office quite as much, especially, for simple things like med refills or just quick questions. And she should actually be able to know how much something's going to cost before she gets it and be able to shop for price.
Excellent way to end. Please join me in thanking Amy and Tom. Appreciate it.
Let me introduce everybody. I don't know if there's going to be the voice of God introducing, so I'll do the introductions. This is Matt Pavel from Doctronic. This is Alicia Jackson from ARPA-H. This is Priyanka Agarwal from HealthX, and this is Michelle Tarver from the FDA. And this will be our panel titled Accelerating Artificial Intelligence Adoption as part of clinical care. Welcome, everybody.
Thank you.
All right, let's get to the first question here. I think we all agree that AI in its many forms has the potential to transform healthcare. And while administrative use cases are being adopted, we're far from fully harnessing the potential of this technology. So I'm going to ask each of you, and why don't we start with you, Matt, and come back this way. From your vantage point, what are the top 2 to 3 blockers preventing AI adoption in clinical care, and how can we remove them effectively?
Sure. So I think the largest blocker is just data sharing. AI has this remarkable ability to parse huge amounts of data, right? More than any human doctor possibly could. And we have lots of data. And it's not just in EHRs, it's on wearables, and it's in chats with Doctronic or ChatGPT or whatever. And that data needs to be shared, that data needs to be processed, and that data needs to be made available to everyone. And the barriers to getting that data for a person need to be lowered. It's pretty difficult for somebody currently outside of a treatment plan, for example, to get access to all of their data, even though it's locked inside health systems. So I think that's probably the most important thing that we can do. I think it would be also interesting to see what we could do about allowing better communication with patients. So, HIPAA makes it sometimes difficult to tell people things that they should hear, and it's not particularly engaging for me to get a message that says, I have a MyChart message waiting. And so potentially improving that is going to engage people a lot more. I think we need to think of patients a lot more as consumers and understand that treating them and making people healthy requires engagement. So I think those 2 would be some pretty big steps in the right direction.
Wonderful. Alicia.
Yeah, what the nice thing is at ARPA-H, we have a pretty unique vantage point, and that we get to not only work across the federal government, but we work directly with companies, and we really see 3 valleys of death. First one is for the really advanced AI that we're all hoping for and marching towards, which is really agentic clinical AI directly touching patients. There isn't a regulatory precedent. There are tons of FDA authorized AI tools and devices already out there, but those tend to be predictive. But we really don't have a model for what this is going to look like. That's one of the reasons we're working with Michelle at FDA so closely and her team on this. And the second one, as just mentioned, was data interoperability. We have all this data coming in, but it's all in different formats. It's in different dialects. It has different constraints on it. But if we're really going to get to this AI that really understands you, all that data needs to be harmonized, brought together, freed to come together to support your health. And I would say the third one is going to be reimbursement, which is the entire reimbursement ecosystem has traditionally been set up as fee-for-service largely, visits and procedures. And we're completely flipping this on its head now. And of course, everyone would love to have an AI agent that keeps somebody out of the hospital a $50,000 bill because it detected, a heart failure issue earlier than it would have been otherwise. And I think the good news is we all know these, and we're all working very hard on them. And I'm thrilled that HHS has the RFI out right now looking exactly at these issues. And we really encourage everyone to please reply to that, because you have an incredible team here who are looking at each of these valleys of death and saying, how do we attack them and overcome them as quickly as possible? Because we all share a vision of making sure that we can really deliver the best care to every American.
Priyanka.
So this is something that I think about a lot, and in some ways I straddle two worlds. I'm a clinician, so when I log on to LinkedIn or Twitter, I see all of the discourse that the doctors are having. I also run a healthcare company, and so I see all of the discourse that's happening around health tech, technology. I live in the Bay Area. And there's an article that is making the rounds on Twitter. It's by Matt Schumer. I don't know if many of you have read it. I think it's had 75 million views in the last 3 days. And it's talking about the revolution that we're in with AI with respect to the speed of model development, the dramatic ways in which coding is changing, in which work is changing. And that's an incredibly important conversation that I don't think certainly the average American has internalized, but I'm not sure that those of us in medicine have internalized it either. And so that's kind of one backdrop. And the other backdrop, I think on the healthcare side, very appropriately is this question around safety and judgment and, how are we bringing AI to patient care? What's the right way to roll it out? And, in some ways, these conversations straddle kind of both extremes, which is, what's the fastest that we can move? And, what's the appropriate or safe way that we can move? And I think both of these viewpoints are incredibly important. And I think the gap is in many ways the challenge that we're facing as we look to implement patient care with AI. And to me, that gap is a huge challenge. And I agree with, I think, the points that have been raised about interoperability. Certainly that's what I work in, so I think that's important. But beyond that, I think the way that we evaluate AI and we talk about the safety of AI is something that we have to really arrive together with a new framing and a new vocabulary. And I think this is incredibly important because when there are real questions about safety that are raised, I think the effect can be very chilling in terms of how we implement these tools. And I was chatting with the participants before the panel. There was a Nature Medicine article that was released in the last week or two. I think many of you all have read it, calling into question the safety and accuracy of LLMs when kind of patients and consumers are using them for medical advice. Unfortunately, that article, the evaluation was on models that are now 1.5 years old. And I really kind of encourage all of us in this room to question the effect of publishing articles in one of our kind of nation's top medical journals on models that are 1.5 years old. And so I think there's incredible need for peer review. I think there's incredible need for evaluation. But what I would love to kind of work with others in this room here is what is a new mode of evaluation that is much more real time. It's looking at the breadth of models that are available today. It's looking at the latest models. And I think that's going to have a tremendous kind of forward-looking impact on how we implement AI. I think the second piece that's related is I think thus far the conversation regarding healthcare and AI has been very much centered on chat. And I think that's kind of where the world started, but maybe similar to what others have raised, I think there is tremendous opportunity also kind of thinking about where Silicon Valley is with AI to go beyond that and really think about, what does it look like for AI to manage really complex care management workflows? And so, I think as a clinician, I'm really excited about that opportunity to really have impact, not just from an informational point of view, but also from a care delivery, care management point of view.
Wonderful. And, Michelle, you are a practicing surgeon and have also been a regulator at FDA, I believe, for almost 15 years now. Please share your perspective.
So this is the challenge with going last. I think I'm the only person in this panel that has Tech for Dummies on my bookshelf at home. But I will say,
That's not true. I should just say that.
Hearing all the input, it's the one thing that I'm going to say, not two or three things, but one thing. I think trust is the biggest impediment to AI adoption right now. And I'm going to say trust in three different categories: the patients, the providers, and the healthcare systems. If there was a recent study done that looked at how patients view AI-enabled medical devices, and they said 60% of them said that they don't think it's being responsibly used in healthcare. Another 50% thought that it was designed to bring them harm. It's a message that has to be undone if we're looking for true adoption, true implementation, and true acceptance of the technology. When you look at the providers have expressed a lot of enthusiasm about the benefits that AI can bring, that it could increase their administrative processes, that it can improve burnout, that it can help with personalization of care for individual patients. But you would think that would lead to adoption. You'd be wrong. In fact, 74% have expressed reluctance to use AI because they're concerned about transparency and reliability. So two of the factors that I've heard in both of those studies and many studies that have been done that may move the needle forward is greater transparency, keeping the clinicians in the loop, and another important point is regulatory oversight. A number of patients and providers have said, I can trust it if I know there's evidence to support how it performs. Now, we're not talking about looking at everything. That is not practical. It's not of benefit to the US public. But what does make sense is looking at what high impact, high risk technologies may look at and making sure there's evidence to support those. We have taken a deliberate step to right size our regulatory touch, to look at the things that matter the most. And the things that clinicians already know how to do, we don't need to do that for them at the FDA. The Center for Devices and Radiological Health has a mission to ensure that the US public has safe, effective, high-quality medical devices and radiation-emitting products that are used in the diagnosis, management, and treatment of their conditions. You already heard Alicia mention that we've authorized over 1,300 AI-enabled medical devices since 1995. That's 30 years ago. And we're talking about what are the barriers to adoption. So clearly there has to be a cultural shift where we learn to accept the technology, learn how best to integrate it, and continue to watch it as it's been integrated into care so that we can ensure that it continues to perform as expected, that it works for all the populations and all the inputs that may be informing that algorithm, and that we talk with patients and providers so that they are educated, as Priyanka already alluded to, educated in the technology and the ways in which to communicate that to their patient base.
Yeah, that's great. As a radiologist, I think of the 1,300 medical devices that the FDA has approved, something like 80% of them are in radiology. And I know that my field, from the time I started in training, we had AI to assist us in our diagnoses, and it has continued to get better and better. But a very important part of that is trust based on evidence, and frankly, trust based on knowing that the FDA has signed off on the tool as being useful and it's something that has gone through the process. So I understand how it's impacted my field. So Matt, going back to building off of a comment you made, you had talked about being able to get data. How are you thinking about interoperability and data management in your work? And how are you connecting those processes to AI? And what could we do at ASTP to help?
So I think most people here likely know that IAS and TEFCA is a tricky path in order to get data. A lot of the users that come to Doctronic are not seeing a doctor or not seeing any of our clinicians yet. They'll start with that IAS path, or they'll start with the AI asking them questions. The accuracy of an AI depends entirely on how much data it gets. And we've built an AI that is particularly good at asking lots and lots of questions. But ultimately, if a user decides to ignore those questions or they skip through them, et cetera, the AI can't give good advice. And that's something that we all want to avoid. So having better interoperability standards and increasing access for the consumer, for the patient, getting them their data, which frankly I think they should own in the first place, is a huge step forward. But it's not just their medical data, because all of the wearable data, as I mentioned before, is incredibly important. And 5 years ago, it was too much data to put in an EHR. And at this point, you may not want to put the raw data in an EHR anyway, but you could certainly put AI processed data in there that would be relevant. There's also data that comes out of the AIs themselves that is not necessarily medical advice, but it's relevant. People discussing symptoms, you understand more about the context, you understand what patients, what things in a patient's health actually bother them more, et cetera, and all of that contextual information is really important. So having a system where you can pass all of that data around and add additional data is incredibly important. There are also some kind of fundamental flaws. So for example, if a patient sees one of our doctors for an urgent care visit, there's no good way for us to notify their primary care doctor that we renewed a prescription or even wrote a new one. It just doesn't exist. And sure, we use SureScripts. And yes, in Epic, a doctor could push a button and pull the SureScripts data in and understand that that was done, but it doesn't exist. And then there's even this kind of consumer focus where I have a friend who's a doctor and her daughter has a food allergy. She wants to be able to kind of share an AI overview of how to handle her daughter's food allergy with her babysitter for a 4-hour window while she's getting dinner with her husband, so she doesn't get bothered. And it would be important to be able to come up with a way to do that broadly, right? I think ACLs and being able to share snippets of data appropriately, a very interesting future. So I think broadly expanding the consumers and the patient's ability to manage their data effectively and force better sharing is pretty important.
Excellent, excellent. Alicia, what are your thoughts about interoperability, data sharing, and how can we better collaborate with ARPA-H to make sure that you're really, envelope-pushing initiatives realize their full potential?
Yeah, I would say the great thing about ARPA-H is because we can actually do and build, we can learn a lot along the way and then pull in other folks to help us along. Like, what are the standards we need? Where's the technology going? It's really nice to be able to learn by doing as we march forward, and we have the privilege of being able to do that so that companies don't have to be the first one through and take all that risk. We have two major efforts here. The first one is our Biological Data Fabric program, and now its expansion into looking at pediatric cancer. And the problem we're solving there is that, let's just talk about pediatric cancer. As Amy Gleason was talking about earlier, if you have a rare disease, you're going to be seeing so many specialists. You have pathology reports, you have genomic data, you have all your clinical records, you may even have clinical notes you want to bring into the picture here across multiple physicians, hospital systems, et cetera. And right now, especially if you're a parent dealing with that, you literally have to have those images burned onto CDs. You have notebooks full of notes. You have different EHR records. You're constantly calling one hospital to another or one doctor to another to try to bring all that data together. And this is just a real nightmare for families who just want their child to be better, who are just trying to take care of their child. And it's a nightmare for the physician who has to receive this data because they essentially get all these disparate pieces of data and then have to actually, basically be an archaeologist and decipher all the pieces and how they fit together and rebuild the entire kind of codex that's been created. And that takes so much time and energy. And so it delays treatment. It delays finding what might be the best care path for this child. And so we have a program specifically focused on this to bring together all those disparate data sets, to harmonize that data, to create one complete package that can be sent from one provider to another. We've now connected 2 hospital systems, and we're now scaling this up to 200, specifically focusing on patients who have pediatric cancer. And the impact of this is just incredible, not only enabling parents to just have a really easy way to transfer data between doctors and different hospitals, but also now you have an incredible data set where for incredibly rare diseases, now, that hospital might have only seen 2 or 3 others who look like you, but now you can go across the entire network and maybe we can find 50 patients who look like you. what worked for them? What are the treatment protocols? Also, what are the new clinical trials? I think there's a statistic that only, I think, 20% of pediatric cancer patients get enrolled in a viable clinical trial at that point. And so that's something we're very, very focused on right now, and understanding how to build that. And it is a massive effort. You hear about it in theory, it sounds simple, but it's a massive effort to bring all these pieces together. But the really powerful thing for us is by bringing it all together for this use case, we show how it can be done, and then we can generalize over so many other different disease areas.
That's very powerful, and I mean, we're really excited to see how all of this work turns out. ARPA-H is really pushing the envelope.
Thank you.
Now, Priyanka, I know that HealthX and Claude had a big announcement, I think, in the last month about grabbing patient data. You want to tell us about all this?
Yeah, absolutely. I think it's just been a really exciting time to be working in healthcare. I think, we have tremendous optimism for, I think, the moment that we're in. And so, I think many of you all know users of Claude can now bring their personal health records and get that context that's so important in ensuring that AI can give individuals, the best answers and insights with respect to their health data. We've just really been blown away with the success of the effort so far. I think many of you all know the way that the flow works is it's very much designed to be a just-in-time, kind of reaching an individual at the moment that matters, which we think is really important with this work. We shouldn't have the expectation that, the average person is sitting around assembling this, perfect unified health record. And so, the flow comes up, and essentially, the core themes as a team that we've really focused on with the experience is first, the foundation for our work is digital identity. I want to be the same, Priyanka, whether I go to Stanford, UCSF, CVS, or Walgreens. From there, we want the records retrieval process to be as simple and accurate as possible. Our records retrieval flows have really, to date, led with TEFCA IAS. For any facility that isn't available via IAS, we have a provider directory service. So that kind of flow together, we think, does a really wonderful job of simplifying the process as much as possible for folks. And I think a good part of that simplification that's not talked about enough is the automatic record location. And we've found that to be just incredibly powerful for individuals. The example I always give is, Michelle touched on this, or Alicia touched on this as well, is, the sheer number of facilities that complex patients have. So the expectation that individuals are kind of going through one by one and finding 20, 30 facilities, I think is a real challenge, and it's a lot to expect from folks. So that kind of automatic records retrieval pulls up where we've been able to find your places of care based on demographic matching. We've done that in partnership with the CSP providers that are so important in this space. We're now matching not only with your current demographics, but with past historic addresses, which is incredibly powerful. So that, we think, has been just a really awesome part of the work. And we're so appreciative of all the folks here that have spent years, I think, making TEFCA a reality. It's been awesome to see it working in action. And so that's been a really big part of the flow. And then we have a really clear kind of consent and permissions layer as well, because I think that transparency and trust is so important. So we want patients to be really clear on what it is that they're doing, how their data is being used, and that kind of transparency and choice to be there. I can share with the team, I think, our team has been really, or the group here rather, our team has been very public about just the success of folks going through those flows. We have 95% of people making it through identity verification successfully, which is amazing. I know Medicare is in the process of rolling this out, so we were frankly blown away by some of those numbers. We have 94% of patients getting at least one record across TEFCA or the traditional provider directory. And we have 88% of individuals getting at least one record through TEFCA, which is really phenomenal. And I think there have been questions about TEFCA, how much does it work? Is it ready for prime time? And we've just been really appreciative of all the collaboration from ASTP, ONC, CMS, the CSPs, the EHR providers, because it really is a collaborative effort to make that chain work across all those steps. And so we continue to be really, I think, optimistic about the space, about the quality of records retrieval. From our perspective, we would love to see just as many providers nationwide as possible live on TEFCA. So any sort of, I think, positive inputs from this group, maybe one day that's some sort of incentive. I think those are all really positive and powerful things that the ASTP, OSTP, and others, ONC and others can do to really encourage TEFCA participation.
Wonderful. Michelle, yeah, please. Michelle, can you tell us about FDA's equities in interoperability, and maybe you want to speak to connected devices, or maybe you'd like to speak more broadly?
So I'll start off by talking about how important interoperability is with respect to medical devices. And I'll start with a use case. Continuous glucose monitors, when they first started, were sensors. Everybody did it their own company. There was no connection with other devices. The FDA leaned in and said, look, interoperability is going to be critical if we're really trying to change and transform how diabetic patients are living. And so we moved forward to help encourage industry to do that, and they did. And that change has completely revolutionized how people who are living with type 1 and type 2 diabetes can manage their care. It led to automatic insulin delivery systems. It led to the ability for patients to interface with apps and other empowerment tools that can help them better manage their condition. So interoperability is a strong driver of patient empowerment. It's a strong driver of collaborative mechanisms across different sectors, not just in the medical device space, but in the EHR space, also in the consumer tech space. So it is transformative. So we are fully behind it. One of the challenges that we have seen, though, is that it doesn't necessarily rinse and repeat in every single arena, and we're trying to encourage that. One of the efforts that we have worked on with ASTP has been USCDI and getting unique device identifiers as part of the USCDI, because that is really going to help us with post-market evaluation of medical technologies, including AI-enabled medical devices. And so we've really been thrilled by that partnership and the release this past summer. The other things that we've been doing, though, is recognizing that we are seeing a contraction of care facilities across the nation. We are seeing that there is a shortage of healthcare providers in many sectors. And the only way that we're going to meet the needs of patients where they are, where they live, is by ensuring that the devices that may need to help manage them at home actually can talk together and talk with their providers. And interoperability is the key for that. So there's a number of initiatives that we've been working on, and I think another good example, historical example, is the DICOM standard, which I know, Tom, you're very familiar with. It allows that imaging technologies to be collected in a standardized way so that all CT, MRI machines collect it in the same manner so that the different technologies can talk together. That helps hospitals, it helps patients, it helps with transparency, and it helps with predictability. And so interoperability, standards, guidance, other things in that arena are things that we are actively working on to try to help drive the industry forward.
I know your office has been very visionary with leading on these efforts, and I can't thank you enough for it, and can't thank you enough for the collaboration. I'm going to hit you back with a question. Your team at CDRH oversees regulation of medical devices, and you've recently published exciting new guidance around enforcement discretion that you're taking with regards to AI-enabled medical devices. Can you take a minute to detail this guidance and goals? What have you been hearing from industry, and how is this supporting innovation?
I think you heard in the early remarks is that regulatory oversight has to be appropriately calibrated to the risk of the technology. And what we saw with clinical decision support is that clinicians know how to do their job. We don't need to tell them how to do that. And if software is accumulating evidence, providing a summary or a collated response to providers that can clearly see how they got to that conclusion, the FDA doesn't need to be in the middle of that. It's not a medical device. And so the clinical decision support software guidance clarified all the different situations in which that's the case. It also clarified when it is a device, when a clinician can't look at all the information that might have gone into an output and determined how an algorithm arrived at a decision. So that is how we made a clear demarcation line. What we wrote into that guidance, there were two major changes. The first is we clarified that there is an enforcement discretion policy for clinical decision support that provides one recommendation. And you can think about that as technology that might give you drug-to-drug interaction. It tells you, no, you can't use that drug with that drug. That's one recommendation. That would fall under the enforcement stipulation. There's also examples where the time criticality was modified so that it's no longer in one of our criteria, it's in the last one. And the reason why time is important is that when you're in a critical situation in any kind of clinical scenario, you don't have a lot of time to question the inputs, question the outputs. You need to make a decision. And so we had to factor that in as part of the risk paradigm. So we took a very deliberate look. We put things into enforcement discretion that made sense, and we added more examples so people could have clarity about what do we mean when we say this is no longer a device, this is not a device in accordance with 21st century cures. The other guidance that I'd like to touch on, if I can, is the wearables, or the wellness device guidance that also spelled out, added additional clarity where a device that is being used to manage, sleep or physical activity or nutrition, that's more in the wellness arena, the FDA does not need to review that. And we clarify that some physiologic markers that people may want to use in that arena don't necessarily need to come into the FDA for review. The important part about that, though, is that we do expect that people who are making those devices that are measuring things that look like clinical analogs have validity evidence, because it's important to the consumers to know what those measurements mean and that they're appropriately couched, meaning they're not saying they're medical grade or clinical grade unless they actually show they are medical grade and clinical grade. We owe it to consumers to be truthful in advertising, and also owe it to consumers to make informed decisions about what they're buying and using. And so we have said that we're not looking at those types of technologies. People can go out and make those and put them in the marketplace. We're focusing our oversight on things that really are important in terms of caring for the patients in the clinical setting. The last thing other guidance that I'd like to mention in terms of how we are bringing regulatory flexibility into the technologies that we are regulating is our AI lifecycle guidance. We went out with a draft guidance that talked about the importance not only of the testing, the validation that is done in the developing of AI-enabled medical devices, but also once it's deployed in real world, continuing to ensure that it's performing as expected, noting and identifying hallucinations and bias and drift and addressing those are really important. I think it ties back into what I said before, which is trust is going to rely on predictability and reliability of the technology. So those are things that we are encouraging to happen. Now, one important thing is we also came out with the guidance on AI-enabled predetermined change control. We know the technology iterates at such a rapid clip. We don't want people to pause, come back into FDA, wait 90 days, 150 days, whatever it is, and then go back in to make the important changes. So we said, look, we know that this technology changes a lot. Tell us at the time of the initial pre-market application, what are your predetermined changes that you're going to make to your software that are within this intended use? We'll review it. If we give you sign off, then fine. You make those changes, you don't need to come back into us. This is our way to adapt to the technology that we regulate, to ensure that we are giving the right touch at the right time to provide regulatory oversight.
Yeah, and I think everybody here and everybody in the environment admires how you're navigating that tight boundary between allowing flexibility and innovation, but also understanding the importance of trust, and trust that can only be given by government oversight to allow for adoption and actual penetration into the market. It's not an easy line to walk, but you guys seem to be doing a great job of it at FDA.
I've got low heels.
So, Matt, we know that physician burnout is a very big problem. I think, Michelle, do you ever get burned out?
Yes.
Yes, so do I. And we know that Doctronic is taking efforts to address this. Can you tell us what's happening in Utah? This is really a first of its kind thing. Tell us what you are, what the product does, how you're working with the state of Utah.
Yeah, thanks. Really exciting stuff. So Doctronic, my lawyers would want me to say that Doctronic is a direct-to-consumer AI health assistant, but given that we're direct-to-consumer, most people call us an AI doctor. Importantly, though, we are an AI doctor with a large clinical practice behind it. So we have doctors licensed in all 50 states and DC. We're available 24/7, excuse me. And patients can talk to our AI, and then they can talk to our doctor, and I'll get to that in a minute. We have seen in the little over a year that we've been around, 22 million AI consults, millions of patients using the system. Our doctors have seen in the past few months more than 50,000 patients. And importantly, our AI has a 99.2% treatment alignment with our clinicians. So I think we're still the only AI company that has published data about this, and potentially the only AI doing this, where people talk to the AI and then they talk to our doctors frequently. So we understand the accuracy there. So a typical consumer experience would look like this. They'd come to the AI. We are, by default, anonymous and private. We follow HIPAA. Someone will just talk to the AI for 15 minutes. It's kind of the average chat. Oh, we're free, by the way. The AI is free. And at the end of this conversation, the AI is going to give a patient 4 diagnoses and 4 treatment plans. And those diagnoses will have a probability, right? And it'll say it's likely this, but it could be this, 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 this. And it's also going to draft a complete physician's note, a SOAP note, that any doctor can take and throw right into their chart and save some time. And it's going to do all of that for free. Anyone can use it. Anyone can get that. It can be anonymous. It can be free. It's compliant. It's secure. It's safe. And then importantly, if they want to see one of our doctors, we do have doctors available. They're available 24/7. We charge $39 for a video visit. It takes about 3 minutes wait time to see one of our doctors. And our doctors are very efficient. So we have doctors that can see 10, 15 patients in an hour. And they say it's because the AI is acting as if it's the best chief resident in the world, right? It's doing all of the work ahead of time. And it's just suggesting, look, this is probably what is it. It could be this, 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 et cetera. Giving all the recommendations for the doctor. So the doctor can have this meaningful conversation with the patient where they're actually treating and they're listening, but they don't have to ask all the basic questions. They don't have to gather the data. We do have TEFCA integrations. We're integrated with EHRs. We're integrated with SureScripts. Our AI is particularly good at gathering all the information it needs to make a diagnosis and to provide a treatment plan without those integrations, which is useful because there's friction in that. Although often after people become a member and create a user account, they do all those integrations, and then it just gets more powerful. But again, because we have doctors in the loop and we've seen so many patients, we know how accurate our AI is. So we approached the state of Utah. So the state of Utah has a program called their AI Learning Lab. It's run by Dr. Zach Boyd, and it essentially exists to test whether AI can do things for citizens of Utah that are beneficial in some way. And it has the ability to kind of alter the laws or mitigate some laws in these trial windows for particular purposes in order to test whether something works. So we said to the state of Utah, look, we have an AI that has a very high treatment clinical accuracy. And we have lots of doctors that are also available all the time to talk to folks if necessary, because it's an AI, and we need to prove that it's safe. And we said that we think we can renew prescriptions, not write brand new, but renew existing prescriptions safely. We think we can do that with an AI. And we think that there's a possibility for us to build an AI that can safely do this for folks in Utah and only charge $4 for a renewal. And frankly, that price will drop a lot soon because the cost of everything is going down. The reason this is important is because medication non-adherence, as all the doctors here certainly know, is a big problem. There are 150,000 preventable deaths every year due to people not taking medications for chronic conditions that they should be taking. And it also costs $100 billion. Now, 30% of that is attributed to friction in the system in getting your prescription. I'm sure everyone here has, unless they're a doctor, has probably gone to a pharmacist and not had a prescription ready for them, and then they had to call their doctor or see their doctor in person or whatever. And listen, we've got 4-week wait times to see a primary care doctor. People are calling 911 because they can't get urgent care appointments. The system doesn't work particularly well for this right now. So our work in Utah is to build an AI that essentially does this. It can renew prescriptions for people. Now, we have human doctors in the loop right now for the first stage, and frankly, for all 3 stages. but the amount of human oversight dwindles to very little towards the end. So how does this work in Utah? Well, what we first did was we built a formulary of medications. So we took the 300 most commonly prescribed medications, and we whittled it down, with partners in Utah, some pharmacists and some doctors, to a list of 191 medications that we felt were safe for this program. So we removed all scheduled substances, we removed ADHD meds, we removed all injectables, which was a little bit controversial because of GLP-1s and because of diabetes, but we wanted to make this a very safe starting point. So with this formulary, we got approval, and the way the system works in Utah now is, if you go to the website or download our app, and we do a geo lookup, and we make sure that you're in the bounds of the state of Utah, we'll essentially ask, what medication do you need to have renewed? AI will, actually, a non-AI will look it up and make sure that that's the right medication. It's in our formulary, right? You can't trust AI for everything. And then you're going to go through the process that is fully run by an AI. It does a lot of things. First, we're going to connect to First Data Bank. We're going to check drug-drug interactions and many other conditions that we need to. We're going to look with short scripts. We're going to ensure that another doctor has already prescribed this medication because we're not writing anything new. And we're going to look at all of the prescriptions you may be taking in short scripts. We're going to ask all the questions. The AI is going to ask all the appropriate questions about whether you need labs, whether you have kind of followed, you're using the prescription properly, et cetera. It's not going to titrate or anything. It's only going to renew those existing prescriptions. And at the end, it's going to make a recommendation. Yes, this is safe. I'll write you a prescription, or no, you need to talk to a human doctor. Now, because we have a national telehealth clinic, at any point in time during this process, a patient can opt to talk to a doctor. Just get on the phone with one of our doctors, and that's free. Additionally, the pharmacists who have to fill this prescription can also talk to one of our doctors anytime, and that's also free. Also, for safety reasons, we've divided that formulary into 9 categories. And for each of those categories, for the first 250 medications we're prescribing, the AI is prescribing, a human doctor reviews every single one. And until we do 250 correctly, doesn't move on, right? After we've done 250 with no issues, then we'll move on to stage 2, which is our doctors will have 10% oversight. So they will be reviewing 10% of all prescriptions to make sure that they're safe. After that, and we don't know when after is, but at that point, there's a kind of this never-ending, there will always be some clinician oversight, right? We don't know what that statistically relevant random sampling is going to be, but it will be some statistically relevant random sampling. So we can ensure that the AI is always doing the right thing. But we've built all of these systems, we've built all of these guardrails, there's a lot of AI running it, but oftentimes it's farming out and just doing these basic deterministic checks, right? You can't possibly get a medication that's not in the formulary. It's always checking for those deterministic drug-drug interactions that's coming right out of First Data Bank. So we're pushing for safety. So that's what we've built.
That's wonderful. You're bringing the future here, and you're doing it in a way that relieves burden on physicians, which I know that I'm grateful for.
Yeah, Director Zach says, his quote is, "The state of Utah wants all doctors practicing at the top of their license." And we're hoping that we can help them achieve that.
That's a great goal. Now, Alicia, there is a lot of exciting AI work going on at ARPA-H, from your Biomedical Data Fabric Toolbox to the Agentic Cardiologist Advocate Program. Dealer's Choice. Tell us what these programs do, how you put them together, what success will look like, and what challenges you anticipate as they roll out.
I couldn't have imagined a better intro than what we just heard about Doctronic. And having built a telehealth company before, I understand every piece of challenge of that, and it's incredible and well done. I'm going to talk about Advocate. It's our newest program. It is incredibly ambitious, and the idea is to build a clinical agentic AI cardiologist for every single American. And that is a massive challenge, but it is the kind of big vision we need if we're going to actually make the leap from renewing prescriptions to actually providing care. And I mean, I know you definitely want to go there. We've talked endlessly about this.
Absolutely.
We're choosing cardiovascular disease because it is the disease that that kills more Americans than any other, and yet hundreds of thousands of those deaths every year are preventable. We know what works. The treatments are simple, they're cheap. It's diet, it's exercise, it's the right medications. It's making sure you talk to your physician at the right time. It's actually not that complicated, but the issue is that nearly half of all counties in the US don't have a cardiologist. The incredible program manager, Hyder Warwick, who's running this program, was the single cardiologist in an area of 150,000 people. The single cardiologist. So there is a great need, not only from the American population, but also from the cardiology community, where we just simply don't have enough. What's particularly exciting about this program is that there's three elements. There's the clinical agent that's going to be patient-facing and delivering care. And when we talk about delivering care, what we mean is integrating EHR, pharmacy records, wearable data to have a complete picture of the patient, be able to nudge them in the right directions, be able to manage their prescriptions, be able to schedule appointments, coordinate care for them, and to be able to elevate to a cardiologist, an in real life cardiologist when needed. The second component of this is the supervisory agent. I'll come back to that because I think this is literally the most exciting part of this entire program. And then the third is deep healthcare system integration and relationships. So three major components in order to launch this. Let's talk about the supervisory agent. So you just heard discussed that right now we have human in the loop, right? Checking every prescription, then checking 10%, et cetera. If we're talking about scaling to millions of Americans who are suffering from heart disease and even more cardiovascular disease and actually focusing on heart failure here, we simply will not be able to have a human in the loop for every interaction. It's essentially human on the hook for millions and millions of patients. And we know now from data that no matter how good you are, if you're reviewing hundreds and hundreds of these records, you're going to miss something. It's inevitable. And so Heather really had this, superlative idea of not only are we going to have a clinical agent, but we're going to create another agentic AI on top of that that's a supervisory agent. And this agent is checking the work of the clinical AI continuously. What is it doing? It's creating an audit trail. It's flagging any issues for clinician review that a clinician will review that will go back in and improve the AI overall. And this puts us in a really different framework where we can really talk about a post-market world, where we can launch these technologies and monitor them continuously. And Heather's building this program such that the supervisory agent, he would like it to be open source, because we don't want it just for heart failure. We want it across every disease category. And we're building this hand in hand with FDA, with Michelle and her team, because that's the only way to build it together. Because if we can prove out this framework, the supervisory agent framework, that we can actually build in the trust, the record, the ability to audit, the ability to track and have that across, that's going to supercharge the entire industry here. And this is why we're so lit up about it. It is an incredibly hard program. Heather will tell you, no, the clinical agentic AI is not the problem, it's the supervisory agent. That is going to need the best minds that we have. It's going to need the best companies bringing their ideas to the table, building it. People who have experience in this field understand what it takes. But that's the thing that just, I think, lights us up the most, is we can be people are not going to build this because nobody wants to be first. Nobody's going to invest in it and take both the technical risk and the regulatory risk. And so we're asking groups to come together. We can carve a path with them. We can work closely with FDA. FDA can then also make sure that they trust everything that's going on here. It's really a unique opportunity. We even have CMS involved. And we're thrilled, and I mean, it's all due to Heather for creating this program. And so, the challenges are going to be getting the human off the hook here, and how do we scale this? But I think that's our job, is to head straight at that challenge and figure it out.
Yeah, and the work you've done here is very much in keeping with ARPA-H's mission of really funding bleeding edge technologies that wouldn't otherwise be funded by the government. So we've heard now about two AI agents that have been, as we say, released into the wild. Priyanka, tell me what HealthX does. Tell me about its partnership with Claude. And how will HealthX drive even more personalized medicine? And what can we do to support patients and providers in this journey?
Yeah, absolutely. So I came to this space as a physician, seeing patients. I was then in the biotech pharma space, and it was just such a challenge working with patient data, working with patients. And, I think there was, at the time, so much emphasis on the institutions that are moving the data, and it really felt like, gosh, there's this missing unlock of the consumer, the individual. And those really first principles problems and thinking are what led me to form HealthX now about 3.5 years ago. And so, really what we say we're building is the modern stack for consumer-driven healthcare across digital identity, real-time records access, availability of your comprehensive health records, and then that consent and permissions layer. And so we essentially want to be the engine for any individual that is looking to use their data in meaningful ways, again, at those moments that matter. So we end up working with big AI teams like Anthropic and Claude, digital health platforms, health plans, providers, any team that essentially wants to make it easier for their patients or consumers to make their health data available for better context. The Anthropic partnership came together in just a very organic way. I met Dario, at the time was talking a lot about their investments in biotech and life sciences, and I talked about there's this incredible shortage of physicians that I think we've all been talking about. What does it look like for teams like Anthropic to help everyday Americans better manage their health, which I think is just a huge theme that we're hearing today. And I think he shared a lot of the same thoughts that many of us here do, and that really led to the foundation of the partnership that we now have. So, the work that we're doing with Anthropic and Claude is live today. They're an incredible team to be partnered with because I think they think a lot about trust. They think a lot about, what happens to that incredibly sensitive data that somebody's bringing to AI. How do we respect privacy? How do we make sure that there's control around how that data has been used? So I think they were a really awesome partner to co-lead this effort with us because that trust is so fundamental to this space moving forward. And I do fundamentally believe that combination of trust that was mentioned, and then this the other half of evaluation and just understanding the quality of what's being provided are going to be so key to this space moving forward. So, I think the work is live with Claude today. We have kind of other similar exciting efforts that are coming to the fore. But, it's very much the early innings where I think right now there's, again, a lot of focus on insights, on chat, on information. I think the work that Doctronic is doing is paving the way in many ways for kind of that next step around, okay, how do we get medications? I think what we're really focused on is this fact that there's just going to be tremendous demand for closing the loop with real-world care on the other side of these chats. And so, what we're really looking towards is what does it look like for somebody to book preventive care out of AI? What are the high-volume, low-risk efforts that can arise out of AI? I think prescription renewals is one. I think a lot about preventive care. I think a lot about, what does it look like to close the loop with your clinician? I think many of us here being clinicians, we realize, well, gosh, the answer isn't a deluge of information, but what does that kind of thoughtful interplay across the consumer and the formal healthcare system look like? And so that's where I think as a team, we're really looking to next and what are thoughtful ways of enabling that next step. And my hope is that this work really comes together in a very collaborative, open source way. I would love for evaluation to be done kind of jointly across many teams. And I'd love for there to almost be a definitive, healthcare MCP. What does that architecture look like across, what are the elements that are needed to move beyond information to actually kind of closing the loop with care? And so I think Doctronic is coming together with a set of inputs. I think our team will, I think ARPA-H will. And so I think the way that America will really lead the way in this space is by kind of these teams coming together in a very collaborative manner. So I think that's something that we're thinking a lot about, having conversations with other teams so that we can kind of build that framework to really, I think, support Americans, which, I think in some ways healthcare is a defining issue of our time. My kids are home from school today in San Francisco. The teachers are striking due to healthcare costs, right? So I think whatever impetus or energy we can put behind this to not only make it work, but make it work fast, I think there's just such a tremendous need. So really, I think personally passionate about this, as I think many of us are.
I want to thank all of you guys for coming here, but I'd particularly like to thank you with your kids being home from school. So thank you for still getting on the plane. So we've got about 5 minutes left, so I will finish up with a question that I was asked in the last panel, and we'll just go, we'll start at this end and go down. And that question is, what does success look like in the work that you're doing and in the roles that you have and in the companies you run and in the agencies that you administer? We have 4 visionary people on stage here with us. Tell us from your perspective, what does success look like?
To me, success looks like when patients use devices in their home that they don't have to think about, that seamlessly integrate into their lives, seamlessly communicate with providers, and adjust to manage their health and well-being in real time. That is what success looks like. That's when we know we've won, when we've improved the healthcare outcomes of patients in a way that doesn't put the burden on their back, but instead empowers them with the tools they need to be powerful agents in championing their own health. So we as regulators have that opportunity to help drive that, and all the work that we're doing is moving in that direction. And it's really exciting to feel the passion and energy on the stage about people who are similarly committed to that goal.
Priyanka.
I imagine we all have the same goal, which is that every American should be able to confidently manage their health in the most informed, lowest cost, timely manner. And I think it's just been such an amazing couple of months working with CMS, ASTP, this administration, all of the teams here. And I feel really excited about the moment that we're in and feel a tremendous sense of optimism. Would love to see kind of that, $5-6 trillion that we spend on healthcare really come down in a meaningful way. I think it's the imperative for all of us to make that happen.
Wonderful. Alicia, what does success look like at ARPA-H and during your tenure?
Yeah, number one, that patients own their own healthcare data and have easy access to it and can easily give it to whoever they need to. And then number two, that no matter where you live in the US, no matter your zip code, it will no longer matter where you live in order to get the best care possible.
Matt?
Yeah, we're fully aligned with giving every American top-of-the-line healthcare at virtually no cost if it's AI-driven, which would be great. I think we're also really working towards building these broad supervisory agents. We have a lot. We have the most chats and the most annotated chats because we have the most doctor visits. And we want to build these systems so that every American, every doctor, every clinician, every government agency can know that these systems can be safe and they can be effective. I think we need that level of openness so people can trust them.
Got it. Well, for me, success looks like ASTP supporting each of you in the goals that you have as you're bringing an AI-forward future and the benefits that it can bring to patients in the healthcare system into the real world. So thank you all so much for being on this panel, and more importantly, thank you for all the work you've been doing.
All right, good morning, everybody. Looks like we're ready to get started, and please take your seats. My name is Sam Cardall. I'm one of Tom Keane's deputies here at ASTP. I want to start by talking a little bit about our panelists. We got Jonathan Fite here, co-founder and chief executive of Beyond Lucid Technologies, Rakesh Matthew, president of Hike Health, and Matt Eisenberg, associate CMIO of Stanford Healthcare. So today we're going to be talking about how breaking down data silos empowers patients and providers. If you were here yesterday, you heard Dr. Keane's speech where he talked about a lot of the amazing work with TEFCA and other projects that ASTP has going on to break down those data silos and, again, help power patients and providers. If you missed his remarks, we have a press release we put out about it, and AHS put out a press release as well. When we talk about empowering patients, I think it's important to talk about how this isn't just a question of yes or no. Are they empowered? Are they not empowered? It's a yes and. Not only is this data available, but is it the right data, getting there at the right time? Is it usable? Is it accurate? And a host of other factors that I'm sure our panelists can tell us about today. There's many fantastic things going on with data liquidity right now. And as we all know in the room, there's room to improve, but we want to make sure we highlight some of those successes and then dig into how we can do more to empower patients and providers. But before we get into the questions today, I want to let our panelists introduce themselves. Jonathan, we'll start with you.
Sure, thanks, Sam. Thank you so much, Sam. So my name is Jonathan Feit, co-founder, chief executive of Beyond Lucid Technologies. My world is the world of the ambulance. So when one thinks of mobile medical professionals, the folks who show up, whether you're calling 911 and they are fire-based, or they are an EMS organization, they are a non-emergency medical transport provider, critical care provider, whether on the ground or in the air, community paramedicine, which is taking those high-risk patients and trying to keep them from coming back into the healthcare system and bringing care to them where they otherwise would be in an extreme health crisis. That's my world. And so what I hope we'll talk about today is, on the one hand, that there are some extraordinary successes. I guess I should say I am an avowed optimist. My wife says I will be routinely disappointed, but I am truly optimistic that if we shine light on what is working, and EMS and fire have taken on the traditional, I guess they've owned their traditional role of being sort of first in, heading toward the need, heading toward the emergency, and they've done some extraordinary things in terms of sharing information with the rest of the healthcare ecosystem to ensure that their insights from the field are available for whoever needs them next. At the same time, there are some extremely human examples, again, I hope we'll have time to go into some of those today, of where the lack of that access to the responders in the field has led to errors, has led to redundancy, has led to death, or people not being allowed to die who wanted to die honorably. Where it's led to overbuilding, thinking, for example, of Los Angeles County during the fires last year, and kind of what observed breakdowns in the process led to in terms of next step discussions that almost go against what everybody in this room is working on. So I think there's some real opportunity to build on those successes, as long as we acknowledge there are some challenges, but there are also models that we can work with, as opposed to assuming nothing works, because there's a lot that's working and very, very well.
Thank you. Matthew?
All right. I'm Rakesh Matthew. I'm the president of Hike Health. We're a boutique consulting company focused on interoperability for payers, providers, and HIEs. And my background is in the interoperability space. I've been in interoperability for about 2 decades now. Started my career doing EMR implementations for small doctors' offices, did a few big hospital implementations. I went on to the payer side, worked with multiple Blues, and then got into the HIE space and started an HIE out of Philadelphia back in 2014. And I was there for about 7 years. And I left the organization as the CIO and started Hike Health. So when I look at where we are and where we came from, in the past 10, 15 years in the interoperable space, I think we have made huge leaps and bounds. But at the same time, there are a lot of challenges still. The key things that comes to my mind is something very interesting that happened about 10 years ago. There was a papal visit. The Pope came to Philadelphia in 2016. And at that time, the local government came to the HIE and said, well, we might have a security crisis there's a potential for a security crisis. And if it happens, how do we know which patient is being taken to which hospital? There are 36 hospitals in Philadelphia, and is there a solution for it? So the HIE came up with a unique solution called UPAL, pretty much connected all 36 hospitals in a matter of 6 months, got all the ADT feeds, and was able to identify which patient would be in which hospital in case of an emergency in real time. And that was a unique use case, right? When we talk about capabilities in the interoperability space, these capabilities have been there for some time. It's more about how you leverage these capabilities for new use cases. With Fire, we have a lot more developers, a lot more capable people coming in and doing interesting use cases. But we need to make sure that the accessibility to the data is there. Today, as a patient, you have a lot of options to get to your data, but how many people are really aware of those capabilities? I don't think a lot of people care about their health unless they are actually sick, or if they have kids who are sick. At that point, you are going to care a little bit more about healthcare, trying to get the records, make sure that when you go from one hospital to another, it follows. When I look at the work that my team does, they are involved in a variety of use cases with a variety of payers and providers and HIEs. I see a lot of traction, and I see a lot of push towards making sure that the patient's data follows them no matter where they go. So hopefully we're going to see something better in the coming years.
Matt?
Thanks, Rakesh. I'm Matt Eisenberg. I'm the Associate CMIO at Stanford Healthcare, SAM. ASTP, thanks for having me. Thanks for hanging in there before lunch, where you're scurrying to try to find a place to eat. I want to start with a little bit of a spoiler alert before I tell my journey. TEFCA is not the first national interoperability rodeo for the federal government. For many of you who know this story, it goes way back, and I'll talk a little bit about that. Stanford Healthcare is an academic medical center in Palo Alto in Silicon Valley with a tripartite mission of care, delivery, discovery, research, and education. But my journey started before I came to Stanford 13 years ago, this week actually. I was at Multicare Health System, and I think Dr. Keane mentioned that the journey up a mountain of interoperability is pretty steep, and I started at one of the trailheads. So when I was at Multicare Health System dates back to 1882, I think it is, when Tacoma General Hospital was started. Tacoma General was not interoperable at the time. But they did become interoperable. I was there with Multicare. We expanded our Epic EHR from the clinics to the hospitals in about 2008. And Multicare was one of the early entrants into what was then the nationwide Health Information Network, the NWHIN, as we like to call it, which now everybody knows is the eHealth Exchange. I like to call the eHealth Exchange the OGQHIN, by the way, so that's my title. And Multicare was about 25 miles away from Madigan Army Health Center. So we were part of this early virtual lifetime electronic record project to connect DoD VA to private health systems. So back then, we connected our Epic EHR to Madigan Army Health Center so that the information of the patients that we saw would go back and forth. That if they were going to travel 25 miles, they didn't have to bring a packet of information. It was in the record. So when I came to Stanford, after the experience at Multicare and realizing that the information really, for healthcare to work, has to flow with the patient and shouldn't be in a bag of records that has to be carted around, as Neil Patterson talked about his story in the HELP committee before the 21st Century Cures Act was enacted in 2016, by the way. So when I came to Stanford, we wanted to make that kind of interoperability for health information exchange and treatment standard operating procedure. And we'll talk a little bit about what that's like now in California and where we practice. And And we wanted to expand our reach, not just within our vendor network, but beyond. And Stanford has continued to try to be a leader. We were one of the 3 original participants in the Epic Nexus QHIN. I was fortunate to be there when we kicked off TEFCA at the end of 2023. And ever since then, I haven't looked back. It was a privilege. I served as the co-chair of the TEFCA Transitional Governing Council with John Blair. And after that, can't believe it, but they brought me back, and I'm now the Governing Council chair. And it's been an incredible experience working with ASTP and the recognized coordinating entity.
Wonderful, thank you. And so moving on to the first question, Matt, like you mentioned, the callback to Tacoma General was founded in 1882, and hopefully patients' expectations about the access to their data has progressed since 1882, sorry. So I want to start by asking you, Jonathan, down the panel, today, what are patients' expectations about the availability of their health data? What does that look like today, and how have you seen that evolve?
I appreciate the question. So first of all, I want to highlight, and I should say from my own experience, it's been very exciting to run the organization that has connected more mobile medical services with public health information exchanges than anyone else in the country. I think that's relevant only as a comment to tack on to what these 2 gentlemen just mentioned. For example, Rakesh, when you talk about patient arriving at a facility, that arrival sometimes takes place by themselves, sometimes takes place by a family member, but especially for those at the lower end of the socioeconomic spectrum, it predominantly takes place in an ambulance. So all of that to answer your question of when the expectation of patients is that their information is going to be available when they need it, and often that's when they need it most in an emergency, right? So we, in this country, prize mobility, the ability to go places, to come to DC, to go on vacation, to go see a loved one, et cetera. And sometimes it hits the fan, and 40,000 deaths on the road occur every year in car crashes, for example. Some of those are preventable. There's a whole lot more folks that don't die but are significantly injured in those car crashes. When 911 is called, either from their phone or from OnStar or from a bystander or in a nursing home or in a school or any of those instances, I think the public expectation is that emergency services are genies and they sort of show up knowing everything about you. Because that's how they see it on TV, for example, right? And that's where we get expectations of so much of what our healthcare is. Right, this idea of this was you know the healthcare ecosystem stops to hear the report, to understand what's coming in, and you've got a heads up on the way in, and so on and so forth. You don't expect that. For example, and I made a list of some cases I wanted to at least touch on if we have a minute here. But one is from a woman who's in the room here. Some of you know Erica, and just yesterday, in the hallway here, she told me about her son who passed of cancer. It's not theoretical, it's happened. So hopefully she's somewhere in the room. She's extraordinary. Her kid was extraordinary. And she told the story of her son being in extremis in the middle of the night, around 3 o'clock in the morning. She got woken up by his emergency as a pediatric cancer patient. This is coming after Dr. Jackson was talking about pediatric cancer in the previous session, right? So let's string these together. She talked about her son, about her need to explain to 7 firefighters and paramedics in the room, in the middle of the night, with her son, who's in these systems, who's in the healthcare system, who's in the registries, who's in the EHRs, and they don't know anything about his needs. The expectation is they would, right? My father, as another example, is a diabetic transplant patient. He lives in Los Angeles. During the fires last year, I had to go down and evacuate him and my mother. It was a remarkable experience as someone on this side of the healthcare ecosystem to find out after the fact, again, he's a diabetic, He goes to Cedars-Sinai. He's been going there for years. He's in all the different healthcare ecosystem pieces that we talk about in this room. And yet, when in the after action of the fires in Los Angeles, the Los Angeles County Fire Chief expressed a wish to the Los Angeles County Board of Supervisors that there were a registry of elder and special needs, disabled, et cetera, patients in the community who would need special help during a disaster, whether it's an earthquake, a fire, et cetera. To which my response was, you're in Los Angeles County. You have like 4 of them. Why don't you use them? Right? And I ended up engaging with Adult and Disability Services for Los Angeles County. Took more work than you would imagine to try to figure out who the right folks are, simply to express the question, if the patients are already in the healthcare ecosystem, as you all mentioned, why is that information not being accessed? It's not a technical problem. And I have a list, if we have time, I prepared a list of states, I've got about 38 of them, that I identified as to whether they are working well with emergency services in terms of access to information, engagement, helping them understand what HIE is, as opposed to a vendor-specific product that might sound a lot like that but doesn't tie into any of these ecosystem partners. Which states are doing well, which states are not doing well at all, which states have completely ignored the mobile medical ecosystem, and which states are often cited as examples of what could be, but their ecosystems are so closed and insular and sort of hegemonic, I guess. They have one vendor for everything. This is, and so it doesn't look like places like New York and California and Texas. And so you can't really replicate them. The ecosystem expects that when you need access to information like a patient's blood type so that you don't give someone the wrong blood and save their life, but cost them their fertility. That's a real conversation happening right now. 3 months ago at the Texas Emergency Medical Services Conference. So I think the idea that I have access to the critical information when I need it, that my wishes will be honored, that my needs will be known, that if I am sitting in the front seat of a car and the car goes into a ditch, and responders in an ecosystem with a health information exchange, or several, arrive at the scene of the crash and extricate my child with hemophilia, and I can't speak to their hemophilia, that they have a way to know that, so that they don't give this patient blood and have them die as a result, right? Or not know that this patient is internally bleeding and I couldn't tell them, and so they've been extricated. The patient dies 6 hours later because they didn't know, and now you have an extraordinary moral injury on that responder, which then weighs on them from a burnout perspective, increase in suicidality, all the things I wish I had known and I didn't.
Oh, thank you, Jonathan. And to your point, like with the technical ability to do this stuff exists, it's only right that patients have this expectation that that information should be available when they need it for them and their provider. Rakesh, you sit at the intersection between the health systems, HIEs, payers. What's your take on what patients expect as far as availability of their healthcare data?
So I'm going to actually talk about a personal story a little bit. So my first son, or my first child, when he was born in UPenn in Philadelphia, and immediately after birth, he was moved to CHOP because he had some severe conditions, allergies that was kind of life-threatening. And it took some time, almost 3-4 months, before we could get him back to normal. And it was kind of very scary, first child and serious diseases. And my wife was scared and told me, well, we're not moving anywhere far from CHOP. We're going to just stay here because if we go somewhere else and if we need his history, it may not go. So it was a decision that we made based on his healthcare that we're going to stay somewhere close to Philadelphia. And and a good thing, I stuck there. I started working on an HIE over there. Great things are happening there. Good. Now, he's grown up a little bit. He loves to snowboard. So we've been going to Vermont during winter so that he can snowboard. And unfortunately, he's prone to accidents. So in 23, he actually fell and broke his wrist. And we took him to the hospital in Vermont. They did X-ray, put cast on, and we came back at CHOP. Well, I'm assuming it's 2023. They had Cerner. This is Epic. The data should be there. So I kind of assumed that it worked. It didn't. So the doctor basically said, well, I can't get to the data, so you got to go get the CD from them and some documents. So the next week, we went back to Vermont, got the information, gave it back to CHOP, happy. Again, 2025, December 31st, he fell again and broke the next wrist. He just got his cast removed this week. But again, it was in Vermont, and same hospital. We went there, and before leaving, I asked, can I get the CD? Let me take all the details. I took all the details, came back to CHOP, and I told my doctor, hey, this happened. Let me look. We already have all the information. Something is working. Yeah. My expectation that as the patient goes somewhere, the data is following him. So I think, maybe it's time that we can move away from Philadelphia at this point, but I'm not going to risk that. But that's the positive side.
So that's great. And building on that, so where I work in Silicon Valley, actually, patients simply expect that to happen. And in fact, it's funny, we've had lots of stories where if the doc says, I can't see the record, the patients will point out where in the electronic health record they need to look to get the information. That's not unusual where we are. California's been kind of a hotbed of interoperability for a long time, both within the vendor-supported network, but beyond. We were early on very, very thoughtfully wanted to make sure that it didn't have to be EHR specific. So Dignity Health Common Spirit was a partner of ours. We did a lot of work with them to make exchange information flow. And the patients really came to expect it. And our providers became, this is how it had to work. And we automated the process. Every time you show up at Stanford, we automate a query for your records. Whether you show up for a clinic visit, you come to our emergency department, or you register in the hospital. It's automated. Last time we looked, every single person who came to Stanford had at least one outside record. It was integrated in the chart, and the providers could see them. 2/3 had 2 or more. We provide radiation oncology services for the VA a mile down the street. We wanted the VA system data to come. And we work with the radiation oncology team every week to make sure that they can actually get access to the data. And if they can't, we've been trying to figure out all sorts of bugs working with the joint HIE to DoD-VA. We were actually one of the first to pilot when they sort of went to the new framework to make sure that connectivity worked. So the good news is if you automate it, and it becomes an expectation for both patients and providers, we can make that a reality. And I think that's the goal to keep going. That's what TEFCA's trying to do, get to that last mile. We'll talk more about imaging data. That's still a bugaboo for us. So it's sort of my next question. Getting that X-ray or getting the digital pathology is trickier, but we're working on that too.
Can I just, if I can tack on to that real quick? Just because I'm glad that Matt mentioned California. And to my knowledge, and again, I have a pretty broad national view of who's doing what where, I believe California is the first state that has actually incorporated a mandate under law for emergency medical services to participate in the statewide data exchange framework and to establish legal parity under law for emergency medical services agencies, whatever their type. So that could be ambulance services, fire services, et cetera, air transport services, et cetera, to participate in that sharing framework, to be able to send data in and to be able to get information out of that healthcare system as well. Standards-based exchange, and I think that's really important here. Right? This was not about saying, I'm going to build something, I'm going to create custom things, I'm going to have to go through a ton of different steps. There's been a set of plans and processes, and partners like Manifest Medics and Serving Communities HIO have been fantastic partners at engaging with that community to educate them, not just to engage on the technology side, but to participate in meetings, for example, with the California Fire Chiefs Association and other groups like that that are the liaisons to their respective communities to help explain the value of interoperability. Also, hopefully, and there's a lot of people working on this, to move the ball along in terms of ensuring that everyone who should participate and is supposed to participate does, and that the information is moving the way it's supposed to. But the framework is there, the legal basis is there. And again, California is really leading the way in kind of a remarkable fashion, but we're seeing others come up behind it. Similar changes to what, the seeds of what grew in California, to use a lovely analogy, I guess, are coming up in other places like New York State and Texas, where we are seeing similar engagement, really an open door to say, you're going to bring these patients in from lots of different ways. Let's make sure the folks bringing them in too are part of that conversation, and it's been a very welcome conversation.
Yeah, you know, we've had several, California has had several integrations with the EMS systems. We built one about 5 or 6 years ago at San Mateo County. They had access at the time to the regional HIE, so EMS workers could actually access the HIE at the point of care. And we had full integration, so it was really kind of, workflow really matters. So in order to figure out who was coming in, we actually tracked the data by rig number, by EMS rig number as they came into our emergency department, and it was miraculous. It's scalable, but it's hard to do, and it would be really a great thing to continue to work on.
What I find just as interesting, if not more interesting, to be honest, than just the ability, I mean, it's miraculous, I think it's the right word, to be able to bring information in and have it be available, but what the second order effects, the derivative effects of that have been really interesting and been engaged by that community too. So for example, in Palo Alto, which is, I guess some innovation comes out of Palo Alto, right? The Palo Alto Fire Department was the first in the state to pick up an approach that I've been proud to be a part of that originally came out of COVID work, actually, in Los Angeles. And it's got roots in Texas and Vermont and South Carolina, sort of has a number of different places, both rural and urban. But Los Angeles really, because of its scale, grabbed onto this idea of tracking what responders were experiencing. Right, because the emergency responders are often the canaries in the coal mine, right? And they certainly were during COVID. I mean, you can track the spread of infection of COVID-19 across the United States by watching the trends in response among, the trends in infection among responders. There's the lines track. There was an interesting study I had a chance to publish in the online Journal of Public Health Informatics, a peer-reviewed journal, if anyone wants to see that. And it looks at how the trends aligned with one another. But that went on during COVID. Palo Alto Fire said, what if you could take the same approach and this idea of interoperability that Matt's describing and this culture of interoperability that they built in the region and use it to track what responders themselves were going through from a psychological exposure perspective. Because contained within the records that they complete, the documentation that they do, again, standards-based, they use the National EMS Information System, which is a DOT-mediated standard, so not under HHS at the federal level, but under DOT, but it is interoperable using those standards-based exchange with HL7-based systems, so you can get that crosstalk, and to take the same approach and be able to say, what are these people going through? And the number of agencies across the country that have started to gravitate to this idea of, what if you could understand what it does to a responder to deal with a dead baby in a bathtub? What does it do to them to respond to a gunshot victim that was a domestic violence call, right? Or to deal with repeated trauma? And we talk about burnout, we talk about the psychological carnage and emotional carnage that this healthcare can do to practitioners, but because of the types of interoperability that Matt's describing, that everyone here is talking about, we have a tool now, and it's a second-order tool. It fell out of the interoperability standards. So it wasn't a matter of saying, hey, I wonder if we could construct something. It was a matter of saying, you're doing it anyway. So you kind of get this freebie of being able to let the data do the talking, as I like to say, and just listen to it. And all of a sudden, you have a heuristic that can allow you to not rely on nice words like we're going to reduce the stigma and open door policy and all that to try to keep people from burning out, which we know is happening everywhere in healthcare. It's not just an EMS or fire thing. It's nurses, it's doctors, it's insurance professionals. Everybody's burning out. But the idea of being able to say, what if you didn't have to ask? Because the data can tell you when there's a problem. And it can, and again, you can call it AI, you can call it being attentive to your team, but the idea is you're going on these calls, you're experiencing this patient care. What's it doing to you? And again, it was in your neck of the woods that this innovation latched onto interoperability to make it more than just technical requirement, but a clinical imperative.
No, that's a fantastic example of how it's a matter of this how we collect this data and how we use it can have real impacts on both patients and providers, EMS providers, as well as many other folks. I want to turn to you, Rakesh, because of the place you sit in, again, where you sit in this sort of ecosystem. In your own words, what does it look like what does it look like for interoperability to empower patients and providers, and what is something what's working right now and what maybe isn't?
Yeah, so I want to just go back a little bit. About 5 years ago, again, the HIE that I was involved in, we actually created a marketplace for third-party apps, patient-facing apps, provider-facing, and payer-facing apps. It was the first marketplace for HIEs at that time, all built on Fire. But it was a little early in the stage at that time, and it didn't take off the way that it should have. But then with Patient Access API, CMS Regulation 9115, and also the new regulations that are coming out with CMS 0057, what you're going to see is the ability to access data is going to keep increasing. But the number of third-party apps and companies that are able to leverage these APIs, we need to increase those companies, and those companies need to encourage people to get to their data. And this is something that I mentioned to you, Sam, is people usually don't go look at their healthcare data unless they have some problem. Usually, you have chronic conditions, or if you have terminal illness, you end up looking at your healthcare data a lot more. For a healthy individual, how many times do you actually log into your portal to see your health information? Not a lot. So the key thing here is, how do you incentivize people to share their data or touch their data even when they're healthy? Whether it's through a fitness app or whether it is through, I'm just going to make it up, maybe Whole Foods or a grocery store can potentially get access to somebody's clinical data, and based on their A1C values, provide better dietary recommendations, coupons. So those are all incentives that can be given for patients to engage with their data without actually, thinking about this from a PHR app perspective. The apps that you do use on a daily basis. Now, the whole push with the CMS line networks and IAL2, the whole idea behind that is to make access easier. So once you identify yourself and you are able to pass the IAL2 credentials over, a responding entity, whether it's a payer or a provider or an HIE, should be able to provide all information back, or whatever information I am requesting from that entity. And I shouldn't have to remember the username and passwords for every portal that these servers or these responders have. That is what actually reduces the usage today. So a lot of people don't know that your payers also provide you with member portals. People log into the provider portals, but there's also member portal from the payers. And all payers that do government programs, whether it is Medicare, Medicaid, CHIP, or ACA programs, they are required to make the patient access APIs available publicly to any third-party app. And if you actually need to use that third-party app today, you should be logged in and you should know the credentials for your member portal. And I'm using the word member portal because from a payer's perspective, that's, they don't say patient portal, they say member portal. And nationally, member portal usage is very low. It's in the 5 to 10% usage. So that means a lot of opportunity is there, but people are not engaged enough to utilize it. So the industry needs to come in and try to figure out unique ways to encourage people to use third-party apps and give access to their data.
Thank you for that. I really like how you phrased the problem of incentivizing people to engage with their data when they're healthy. And I wanted to ask Matt, at Stanford, is this something that you all are thinking about, and how are you approaching this challenge of, maybe people have more access to their data than they had before, but how do we get folks to engage with their data maybe before they're sick?
Well, so we've really focused on patient experience and access. We were early on actually making sure that you had automated through your phone access to your patient portal. We have remarkable adoption of our patient portal. It really is for us a patient experience driver. We have, I think last check, 98, 99% of our patients, they get access. But I've joked about this before. My kids use their DoorDash app a whole lot more than they use their portal, for sure. And you're right. I mean, people access their portal, and I access my member portal, but as well as my provider portal. And I do have 2 provider portals, but I have two bank apps on my phone too, by the way. So it would be nice if it was easy to go back and forth. It really depends on the patient. Depends on the patient experience, the patient need. So for folks who've been working with portals for a long time, what people most like about it is being able to see their information. So God bless the 21st Century Cures Act. EHI is now ubiquitous. Patients come to expect that too where we are. We have promoted that constantly. We want to make sure they have that. They can do some patient-driven exchange through their portals. That happens a lot. It certainly happens for caregivers. That happened when I was taking care of my mom, my elderly mom. I would pull up her portal when we went from doctor to doctor. If they couldn't see it in the electronic health record, we'll just pull it up on the phone. And that was helpful. But patients want to be able to see their information, contact their provider and communicate with the provider and the care team, pay their bills, and that's what they use it for. And it really depends on where you're at. It's different if you have a life-threatening acute illness. It's different if you have chronic diseases that you need to manage. And it's completely different if you're generally pretty healthy, don't see the doctor very often. But big fan, love portals. Everybody should do it. And we just need to train everybody how to use them effectively.
Thank you.
I have thoughts.
Please.
Speaking of portals, so from a patient perspective, interesting, relevant. I don't have anything to counter on that, nor would I want to. But, and I mentioned earlier, and certainly this team has heard from me before, that I'm all about, I don't think we can move the ball forward if all we do is either speak sunshine or rain on everything. I think we need to have models where we can look at what's working and what's not working. And so this notion of credential pass-through, for example, that Rakesh is mentioning, and access to information in easy fashions that Matt is mentioning, is working very well in some places. And I wanted to talk, but I also want to talk about one where it's not. And it's caused a problem that's ongoing in its 4th year now, at least. So as examples, the state of Oregon, it's a point of pride for me that my organization powers the end-of-life medical order registry, the Oregon POLST registry, that's connected to emergency service providers across the state. It's a remarkable thing to work in a technology that has literally a margin of error of 0 tolerance, right? You either get that document right and honor the patient's wishes, or you don't. So it sort of takes the technology needs to an extreme when you look at a case like that. And the degree to which the community has engaged in interoperability is extraordinary in Oregon. And I'm sure some folks, I know some folks from Point Click Care, for example, are here in the room. So Point Click Care and their Emergency Department Information Exchange has been a ready partner, a working partner, and an automation partner to connect the information that goes from the registry into the hands of the emergency responder, hybridizes essentially with the rest of the information that they're capturing at the patient's side in a moment where the patient needs an end-of-life medical order, right? So you're talking about cardiac arrest, stroke, et cetera, serious health issues. And it takes all that information and it makes it available in an EHR at a receiving hospital. Wow, right? That's an amazing thing. And these are different companies with different motivations and different business models and different whatever, all coming together to solve a problem. Something similar happened in New York. Okay, it's tough to crack the skin of New York. New York's a complicated place, and New York City even more complicated. Just ahead of the new year, I had the opportunity to work with Montefiore Medical Center and an ambulance service that shared data, wanted their information to be available at the hospital essentially as soon as the patient arrives, ideally. If not at that moment, then while the patient's still waiting to be seen in the emergency department, et cetera. That worked. The partnership there was between different electronic patient care record vendors on the EMS side, Epic, Rio, hospital system. People came together, portal access, right? Information showed up from the EPCR in the ambulance, showed up as discrete data inside Epic's system. I mean, there were pipes along the way that converted Nemesis to HL7 so that the data could go through. The standards come out of your office, right? Those are all CDA standards. So you're taking one form, converting it into another. This is wonderful. At the same time, there is an ongoing issue right now in the state of Arizona. And Arizona and Colorado have the same health information system, same health information exchange today. But I want to highlight this because what was Creo and the Quality Health Network, for example, two different HIEs that are now part of one larger HIE contexture, behave differently than Arizona's, which was at one point called Health Current. I don't think we're going back to NW HIN, but we're going back. And the automation from the Colorado agencies into what is now Contexture has worked since before COVID. It was fantastic. Small EMS agencies, rural EMS agencies, western slope of Colorado, suburbs of Denver, all that information was able to move. By contrast, in Arizona, going back to at least 2022, fire services have been begging in writing for access through their elected officials directly to the HI leadership, et cetera, for access to end-of-life medical orders, DNRs, advanced directives related to their patients while they are in the most extreme health crises you can imagine, right? These are patients in nursing homes, they're patients in schools, they're patients who have gone through the effort of documenting their health needs and filing them and putting them into the Arizona Advanced Directive Registry. And the answer that the organization has provided to the responders was, log into our portal. Okay, you've got like 30 seconds before this patient is either brain dead, right, or resuscitated against their will. And the downstream flow down catastrophic effects on patients, families, and responders is why I get so passionate about this. And you're not just talking about healthcare, you're talking about people losing jobs. Because if you have a loved one who is now in a vegetative state, right, and needs care in their home for potentially a very long time, not everybody can just hand that off to somebody else. Somebody has to make sure they're okay and they're still fed and so on and so forth. Or what if it turns out that this patient wanted to be resuscitated, but the more recent document around that was not available to those responders? So they did what they thought was right and let that patient pass, but since they filed the last form that they had with them, they've now had a new family member, like a grandkid, and they have a new desire to live. And so portals are a wonderful answer in some settings. But if you have 30 seconds and you have to go through 15 different steps and two-factor authentication and so on and so forth, it's not viable. We have to map that onto the clinical workflow too.
Well, thank you, Jonathan. That's a powerful example. And I know we're all standing between everyone here in lunch today, so I want to wrap it up quickly here. But first, I want to give, Rakesh, give you a chance. If you have any closing comments you'd like to make, I'm happy to open up to you.
I will keep it very short. I have personally spent almost 2 decades in the interop space. I think we are at an inflection point. We have the right technology. AI is going to be a huge enabler in the future. And we also have the administrative support to push forward on actually doing something in the next 12 to 18 months. So I'm hoping to see some of these silos being broken and some of this portalitis ending. So that's my parting thought.
Can I borrow that?
Sure.
Thank you. And Matt, I'll leave the last word for you.
Well, it's been a long journey, but I think we're going a long way. There are a couple things we do need to work on. The last mile of provider offices, small offices that are not on interoperable systems or still on paper, where a fax machine is their only interoperable tool. We need to work on image exchange. I saw that the RFI on image exchange is important, both for radiology and pathology now. And data quality is important. The last thing I'll say with the last few seconds is thanks for hanging in there. Join TEFCA. I think it is the way for us to move this forward. Get involved, learn more. We had a great session yesterday with the RCE. I'd love to talk more about it.
Awesome. Thank you all. Appreciate it.
We will now adjourn for lunch.